So starting again, this is the bleeding management and coagulation monitoring during liver surgery. This is the lecture. Bismillah ar-Rahman ar-Rahim. This is our National Liver Institute, the old building and the new building. Here I have really to, importantly, to say that Professor Magdi Khalil has a lot to do with the new building. And we have to really to thank him for his efforts to erect up this new building with about 430 beds and a big ICU and OR rooms. The objectives of this lecture is to speak about our experience in Egypt and the world concerning ROTEM as a monitor and how it is used to guide blood transfusion and coagulation medications. These days, we have coagulation medications. We have ampoules for fibrinogen. We have ampoules for prothrombin complex concentrates. And we will go through the research from our National Liver Institute. I have here to represent my conflict of interest. And I have to acknowledge Professor Klaus Gorlinger for his assistance in preparing this slides and joining us in several research projects between Egypt and now between Saudi Arabia and Germany. This is the type of liver that we are all working through and anesthetizing patients with liver cirrhosis. As we all know that hepatitis C is one of the main causes of liver cirrhosis in Egypt and in the Middle East. But it is now decreasing in incidence with the very wide nationwide program of detecting hepatitis C in Egypt and using advanced antiviral medications. This is type of surgeries that we do during liver resection or in donor livers. We can split the liver into two pieces. We can remove the left lobe, the right lobe, and we have to do this in cirrhotic tissues, which is quite different from in the Western world. In the Western world, liver resection is done on a background of a healthy liver cells. But in our Middle East zone region, and particularly in Egypt, it's done in a background of a cirrhotic liver. Here, blood loss is more. Here, coagulation problems have to be tackled accurately. In order to do this, we've started using viscoelastic tests. This is one of the advanced apparatuses for this. It's called ROTEM. And they also have another ROTEM Delta, and they also have another more advanced called ROTEM Sigma. But this ROTEM Delta is very important because it can measure the platelet activity as well as the coagulation factors in the blood. What is this ROTEM? It is called, R is for rotational thromboelastometry. So it measures the viscosity and the elasticity of a clot formation. And it will specifically tell you what and where is the problem in the clotting process. Is it due to excess heparin? Is it due to fibrinolysis? Is it due to platelet hypofunction? It's very important. And not less to tell you that these days during the COVID-19 pandemic, ROTEM role in saving lives of patients is now becoming more significant. And they are starting to realize how through ROTEM we can diagnose hypercoagulation and even hypocoagulation in COVID-19. But this will be a separate topic, and we are preparing a review about this topic, and hopefully we will be published soon. What is the diagram that we get out? We get out a beautiful diagram like a fish-like diagram, and it gives you through its parameters. As you see, we have in green the clotting time, and this clotting time has a normal range. If it is prolonged means that we have a problem in the clotting factors, and we need to give fresh frozen plasma. But if the one in blue, MCF, is thick and the graph is big, then we have hypercoagulation. But if it is a thin graph and a low MCF, maximum clotting firmness in blue, then this means we have hypocoagulation. In this instance, we have to contact the blood bank and ask for platelets or cryoprecipitate. And nowadays, why do we need cryoprecipitate? Because cryoprecipitate is rich in fibrinogen. Why do we need platelets? Because platelets is very important for the blue, the maximum clot firms. So we will not order fresh frozen plasma, for example. Cryoprecipitate contains fibrinogen, and these days fibrinogen is now produced as ampoules. We can use it as ampoules as well. We can see now in black maximum lysis, which shows and indicates that this clot, if it is abnormal, this clot is suffering from fibrinolysis. And in this instance, the treatment is antifibrinolytic agents as tranexamic acid. So let's go through the slides and we will see the defects when we go one by one. What is the importance of this rotor? It is going to help us during surgery to know if the bleeding is from surgical reason or it is due to coagulopathy. The European Society produced its own guidelines from the European Society of Anaesthesiology, and it was published. And one of the most important authors in this is called she's a female doctor, Zibla Kozak. She's from Austria, and she did a lot of work in producing these guidelines. These guidelines from the European Society relies very much on recommending transfusion through viscoelastic tests like Rotational. Also, the American Society of Anesthesiology Task Force on Perioperative Blood Management created their own guidelines and implemented that these guidelines should be followed in any trauma case or in hemorrhage. And they said that during intraoperative and post-operative interventions, it is important to monitor platelet functions, viscoelastic hemostatic assays, and there is two types of viscoelastic hemostatic assays, one called TEG and the other one is called Rotational. TEG and Rotational, actually the same, are doing the same job, but their technology are a bit different. There is now also something new coming up, depending on dry reagents, but it is a third company producing another viscoelastic hemostatic assay. So the American Society recommends monitoring blood coagulation with Rotational or with TEG or with viscoelastic tests. The practical guidelines for perioperative blood management in the American Society of Anesthesiology depends on not giving pharmacological treatments unless it is indicated from the Rotational trace or graphs, like antifibrinolytic agents, like tranexamic acid. And in the bottom of the picture, you can see the PCC, which is the abbreviation of prothrombin complex concentrate. Nowadays, instead of giving fresh frozen plasma, which we give when we have a prolonged clotting time, fresh frozen plasma needs to be ordered from the blood bank, and you have to order it in advance to have it immediately in the OR time. It might take some time to come to you in trauma situations, but nowadays it's been replaced by prothrombin complex concentrate ampoules, which we store in the fridge. In Monofia University, in the National Liver Institute, we had for some time, but with a special import, because it is now becoming, just maybe this year, becoming illegal to use it in Egypt. We have a stock of prothrombin complex concentrate and fibrinogen, which we can use to interfere immediately if we find during bleeding, during transplant, that we are in need for it. The Journal of Trauma and 2014 Consensus Conference on Viscoelastic Tests produced their own guidelines. And as you can see, we have several graphs and figures of the rotor. In the first graph, called XTEM, which measures the extrinsic pathway, and in the last graph where you can see fibrinolysis, this is when it is indicated to give anti-fibrinolytic agents like fibrinolysis. If you see this picture, this is a strong indication that we should give tranexamic acid. So rotum and bleeding management in hepatic patients, how did the monitoring of coagulation parameters affect our management of hepatic patients? It managed to reduce both bleeding and thrombotic events, and as published by Klaus Gorlinger in his book, it reduced both bleeding and thrombotic events. In acute gastrointestinal bleeding, like in varices, esophageal varices, restrictive transfusion strategy helped to reduce portal hypertension and transfusion-associated overload. Also, in hepatic patients who are going to be prepared to undergo invasive interventions, like endoscopies, for example, using rotum did reduce the prophylactic use of blood before these interventions. This is a very nice picture of fibrinolysis. As you see, the fibrinolysis here, and its treatment, as we said, is tranexamic acid. We go, my story started with rotum in 1991 when I was in England, in Leeds, preparing for my MD thesis. At the same time that Professor Magdi Khalil was working on muscle relaxants in Paris, or in Paris, en français. Dr. Magdi Khalil speaks very good French. And in fact, we both left Egypt almost on the same time. They were preparing us for the coming up liver transplant program in Egypt, which was one of the first in the Middle East. My protocol was surprisingly on tranexamic acid use in liver transplant. And it was published in the Clinical Transplant. And we managed at that time, when liver transplantation was cadaveric, and it was in Leeds, and it was at the beginning phases, there was a lot of blood loss there. And we used to use veno-venous bypass. When we started using tranexamic acid during the liver transplant, prophylactically, it reduced the blood transfusion. So we go to the next slide. What is happening today? We are not using tranexamic acid prophylactically these days in liver transplant. We are using it today guided with rotum grafts. And this is based on many observations in that not all the patients are similar. If you give tranexamic acid to every patient, and this is, you should take in consideration when doing non-transplant cases, because some of these patients have genetic hypercoagulation. Some of these patients might react abnormally to tranexamic acid. So you must find true evidence of fibrinolysis on the rotational thromboelastometry prior to ordering or administering antifibrinolytic agents. Klaus Gorlinger sent a very good article in 2006. We continue with our research. This is the picture of Dr. Maha Lotfi. She did a very good work on her MD thesis between Cairo University and Menifee University in the period between 2009 and 2013. She went abroad and presented her work. She did her work in a group of volunteers who are donating half of their livers. And at that time, there was a big row that these patients or these donors, volunteers who are very important because they are not patients and they are going in to donate part of their liver to their family relatives. There was a talk that on the 10th day post-surgery, these patients, there was some reported case presentations that they develop deep vein thrombosis because they become hypercoagulable. So we decided to study this in a thesis, an MD thesis, presented in Spain during the International Congress for Liver Transplant Society, and it was published as an abstract in the Liver Transplant Journal. We proved that there was no hypercoagulation in the group study, and that there was no even hypocoagulability. Despite the hypocoagulability, you could detect in INR and prothrombin time, but it was safe to provide these patients with epidural analgesics. But we actually found something significant, that Rotem studies and parameters were not in relationship, were not in good relationship with standard coagulation tests. Rotem is giving us something, and these coagulation tests are giving us something. Maybe Dr. Magdi Khalil will recall what he taught us, that sometimes you see liver patients coming in with high INR, and then you realize that they have portal vein thrombosis. How come they thrombose and they have high INR? Here we learned here that INR and active partial thromboplastin time and standard coagulation time represent ex vivo studies. They don't represent actually the whole blood clot picture. They represent the plasma without platelets, without RBCs. They represent the blood sample after centrifuge. But rotational thromboelastometry and TEG and other viscoelastic tests will represent the whole blood as a whole in the coagulation process. And here we learned that there is no significant correlation between Rotem and other standard tests. The study was very good. It was cited 4 times in PubMed. This is recently, and many times in other non-PubMed citations, and it was part of a textbook in London. Ahmed Badawi from Damanhur, and he was from Alexandria resident, and he's now working in Helwan University as a lecturer, did his MD thesis with us, with Alexandria and Menifee University, and came up with the same, but he did it not among donors. He did it among cirrhotic patients suffering from hepatitis C, who are subjected or scheduled for liver resection to remove a tumor. He found that Rotem is not in a good relationship with prothrombin time or clotting time. And this was published in the Journal of Anaesthesia. A lot of work has been done on donors, and I had the privilege to have my first chapter published in the University College, King's College Hospital. This is out on market this month in London, and in it we put all this research, and in it we put our understanding of how to manage anesthesia for live donor hepatectomy. In it, we included our conclusions of those 2 important researches by Maha and Ahmed Badawi. Rotem as a coagulopathy therapy. What can Rotem help us to do? It can predict. We can use Rotem to predict if this patient is going to bleed or not, to predict if this liver transplant patient is in a good state to go through liver transplantation. or he is very bad and suffering from severe coagulation problems and would require specific measures. This was published in a nice research by Nermin Fayet, who is working currently as a consultant in Dresden in Germany. She did a very good work, and she did present a very good couple of papers, 2 or 3, talking about how rotem can be a very good predictive for bleeding intraoperative. I recall one of those papers was done with Professor Magdi Khalil, and we will go through it in the next few slides. So, preoperative thromboelastogram can help us detect and distinguish patients who will bleed. And here I can recall a case during my work in Cairo Liver Institute. Before we do liver transplants, we do a baseline liver rotem study or parameters and have a look at it just to make sure that our patient is not bad. In this patient, we could detect severe fibrinolysis before we touch him, before we put central lines in and big invasive lines. And that patient was treated with tranexamic acid prior to the anesthesia induction. And he went through the surgery with very minimal blood transfusion. And thank God that we have a rotational thromboelastometry that could predict fibrinolysis. While when you look at the standard coagulation tests, including D-dimers, FTPs, none of this could be released. None of this could tell us something that we are facing a severe fibrinolytic situation. This paper was published or cited 8 times in the PubMed Central articles, and this shows the importance that these people, these data was important for other researchers. We have to say something very important. Why am I going back? Oh, it should go in for, okay, here we have to say something very important. We should encourage research wherever your field is. If you're doing cardiac surgery, if you're doing day surgery, even if you're doing kidney transplants, if you're in neurosurgery, research is the base of all textbooks. Research is what we owe to the level we reach today. Every consultant should have at least one research project a year where he can present his experience through it. Here comes Dr. Magdi Khalil. In 2011, we started because our cases were very difficult in the Liver Institute. We have hepatitis C more, and it was aggressive. So we started using prophylactic low dose of recombinant activator factor 7. And we found significantly good results. He used, Dr. Magdi had this idea of using 20 micrograms per kg, which at that time showed us a significant improvement in the coagulation parameters. 4% of our patients in control did not receive blood, while 36% in the Novo 7 group did not receive any blood transfusion. And 24 received only packed RBC. So we, for the first time, we started to know that there is something called transfusion-free liver transplant. That was published in 2012 in Anesthesia and Clinical Research. It was cited 8 times as well. And this is a nice diagram showing that in 2013, this was our blood transfusion. 100% of our patients have blood. Look at the no transfusion started to increase in 2007 and started to be in 2009, 43 cases, 33%, and 36 and 40% by 2013. So this protocol of using recombinant factor 7 was quite valuable. The plasma transfusion was reduced. But With the getting more in the studies and work, and with Rotem becoming more available in our OR, we started reducing the amount of recombinant factor and not using it unless we feel that we have signs of coagulopathy on our Rotem. So instead of using it prophylactically, we started using it with a Rotem-guided algorithm, as presented in many international studies like Haas and Klaus Gurling. This is a picture of another colleague, Shireen Dawood. She is a MD, a researcher from the Ministry of Health in Cairo. Dr. Shireen did her MD thesis about monitoring and detecting heparin during liver transplant. We all know that heparin can be secreted endogenously, so we call it heparinoids. These heparin can do a great destruction and trauma to our liver transplant patients. And we could face problems with it if it goes unmonitored. We don't know the extent of this heparin-like effect, so we started this protocol study, perioperative heparinase rotational thromboelastometry monitoring during and after living-related liver transplant. Here in the graphs, as you can see in the first graph, we look at the CT. CT reads in the circle red. It reads 400, almost 500 seconds. It is very prolonged. But when we give heparin, it is reduced. So this is a very simple test that tells us that this patient is suffering from heparin-like effect. It is very difficult to imagine during liver transplantation that we could give protamine sulfate, but like we used to do in cardiac surgery. And nowadays, even cardiac surgery in cardiopulmonary bypass surgeries, they are monitoring their heparin-like effects and the doses that they give to reverse protamine with Rotem. They started doing a lot of studies in which they can tailor the amount of protamine they are going to give to reverse the heparin-like effect that they use during bypass. In liver transplant, that was unusual. But we only locate it or treat it if it is seriously affecting the bleeding. And we could recall case presentations worldwide about it. One was in pediatric liver transplant in Brazil, and the other one, for me, myself, I used it in one of the liver transplant cases in which it bled severely after reperfusion. And only was this patient rescued when we decided for the first time in maybe Egypt, I don't know other centers, but for me in Egypt and even Saudi Arabia and even in UK, where I did liver transplant, we never used protamine, but here I was actually encouraged to use it because I could find evidence of heparin-like effect in the Rotem trace. I could see it clearly in a prolonged CT that is reversed by heparinase, very clear. And the patient, the surgeons cannot stop the bleeding, and the patient is bleeding massively. We gave the protamine in this case, and the patient survived. So this shows you how important. How could we know without rotational thromboelastometry that this patient is in need for protamine? If we do not measure the traces of Rotem, we will actually give him fresh frozen plasma, cryo, and I don't think this patient would have survived. But when we were able to locate the problem of heparin-like effects, we could then encourage ourselves to use protamine, which we don't often use it. This research was presented in Copenhagen, or as they call it in Denmark, Copenhagen. It presented in 2018, and it shows this is the phases of liver transplant: preoperative and hepatic and reperfusion. Most commonly, we find heparin-like effect in the reperfusion, after reperfusion, and it subsides automatically on its own. It comes in for 5-10 minutes, half an hour, and then it subsides. By the first day and second day, you can see in the yellow colors, we could find some traces of it. But what was important in this research is the severity of heparin-like effect, the ones in red. The patients who suffered from a severe heparin-like effect during reperfusion was those who suffered from high rates of mortality. This was a discriminator for us and could discriminate patients who will need serious attention because they are going to suffer from high complications. This is called severe heparin-like effect. So we produced a ratio for this heparin-like effect depending on the parameters that we get from Rotem, and we could say that if this ratio is more than 2, then this patient suffers from a severe effect. These are the 2 cases where protamine was used. One was published in the Pediatric Transplantation Journal in 2009, and the other one was included in Gorlinger textbook about protamine overdose can prolong coagulation times. In that we should, when we give protamine in liver transplant patients, be careful and give it in reduced dose because it itself can lead to prolongation in the clotting times. Now, as we mentioned before, new coagulation management drugs are available these days. We have fibrinogen concentrates. It comes in 1 gram ampoule from Hemicompletan company, and PCC, prothrombin complex concentrate. This first one, fibrinogen, replaces cryoprecipitate. The second one can replace fresh frozen plasma. So cryoprecipitate, we all know 1 unit contains 300 milligram fibrinogen. You have to order it from the blood bank, and it has only 3 to 4 days half-life. The other one, fibrinogen, it has 1 gram. You can put it in the fridge and becomes available at the time you need it. It is available in Europe, but its entrance in the Middle East started to enter in few centers in Egypt and in few centers in Saudi Arabia. I could see it also in Kuwait and in Emirates. So we have to have these ampoules standby in our OR in the fridge because it can save trauma patients. It can save any patient bleeding when you will diagnose a problem that indicate the use of these ampoules. So I tried to mention them here because we should really be familiar with these ampoules, which are starting to be part of our coagulation management in ICU even and in OR. In Switzerland, in 2017, we had one of our colleagues called Yasmin Kamal, Yasmin Abdesalam from Liver Institute. She monitored patients with Rotem, whom she thinks they have hypercoagulation. This was the first time. You see, when we talk about Rotem studies, most of the Rotem studies are talking about hypocoagulation. Very few are talking about hypercoagulation. This study was used as a pillar for COVID-19 because very few studies were done about utilizing the Rotem to monitor hypercoagulation. We realized during our OR liver transplant that some patients develop hepatic artery thrombosis. Others don't, despite we are using the same guidelines. It came to our knowledge that these patients might suffer from genetic or acquired tendency to hypercoagulate. So we studied these group of patients in which we thought they have genetic and acquired, and we came up with important topics or conclusions. And this was published in a very important journal in Germany called Transfusion Medicine and Hemotherapy. And these guys in the transfusion medicine, the reviewers and the editors had to contact us and contact Klaus Gorlinger to make sure that this data is okay, because it was the first time to present hypercoagulation. Am I running short of time, Dr. Walid? Am I okay?
That's 40 minutes now, I think, yeah.
Yeah, I'm going to conclude in less than 5 minutes. Okay. So we found signs of hypercoagulation in FIBTEM, and this is, as you see, it becomes hypercoagulation at 7 days post-operative. We did another study, and we found that there is, by Hisham Gamal, and we found that there is genetic, and that was a discovery. In liver patients in our institute, we found that 52% have genetic mutations that we should take care of in the next few studies. One of the last things that we need to mention in Rotem is that we could measure the platelet functions. Platelet functions is very important to Rotem, and that was an addition to it. And as you see in the lower two graphs, we could see the platelet activity. If it is low, then it becomes better with liver transplantation. This is Dr. Iman. She presented a very good topic about monitoring platelet functions for 3 weeks in liver transplant, was presented in the anesthesiology meeting in the States in San Francisco. And she found significant, important, hyper increase in platelet functions after 2 weeks of transplant. 2 weeks of transplant, we have hyperactivity of platelet functions in which can lead to hepatic artery thrombosis. And this is the first time that liver transplant anesthesis role expands to 3 weeks after transplant. Make sure that this hyperactivity of platelets need to be put under control. I conclude with this latest textbook, which will be published in the States, in Texas University, sometimes next few months, and will include all these past 10 researches that we presented from Menofia Liver Institute. Thank you very much. Thank you for the teamwork, all the members in Liver Institute and the National Liver Institute. Thank you, Dr. Magdi Khalil. Thank you, Walid and Dr. Tharud, for allowing us this opportunity to present a topic about coagulation monitoring in liver transplant and how important it is. Thank you.
Thank you, Khaled, for this illustrating presentation. I know to understand hemostasis and coagulation, it is not a one-way journey. It is a to and fro, where something you might be treating for coagulation might be go to bleeding and so on. So I know you simplified the subject very, very much. And I just declared to you that most of our candidates in the Liver Institute are attending the presentation, which is more to enforce our experience with that. I have some good data, just completing the effort of your colleague in the Liver Institute, that Imana was going now and all her colleague going to present something about the importance of Rotem in COVID.
Yeah, very good.
Yeah. A great topic. Okay. Now a question from I don't know where is the question. No question up to now. I think Walid, you asking Muhammad for Khaled. If I just chat. What about Rotem for COVID? Okay. You have some thing to
Yes, yeah. Would you like me to answer this question? Yes. Rotem is very important in COVID. And these days, they are starting to use Rotem to monitor COVID patients and detect their hypercoagulability. And they found something very interesting in COVID patients, in which these patients are resistant to fibrinolysis. They don't want to break. And that was one of the main reasons of hypercoagulation among COVID patients. We are writing a review article these days, and we're in the process of publication, in which COVID-19 patients suffers from fibrinolysis shutdown or hypofibrinolysis, and they are indicated for fibrinolytic therapy. They are using tissue plasminogen activator to break down the clots, but recently we've noticed something very important. You mentioned Dr. Iman Awad in Menifee University, and another colleagues in Beni Suef University. They presented that inhalational streptokinase could be used to give a local effect in the microcirculation in the alveoli. It breaks down the fibrin, it breaks down and clears the alveoli, and very promising results are coming in from antifibrinolytic treatment for COVID-19 patients.
Just another question, also from Muhammad Salim. He asked a question. I think this is a major question asked by many about number one, what is the difference between Rotem and TEG?
Yes, there is Rotem. The difference is in the technology. In Rotem, the cup does not rotate, but instead the pin rotates. So it's basically a technology and reagents difference. In TEG, the cup rotates, the cup that contains the blood. So it is a technological difference.
Okay.
Rotem and TEG are actually the same. Rotem and TEG are doing the same job.
Another question also from Muhammad Salim. Visioelectric tests are long time tests. Edit have a role in emergency situation?
This is a very good question. Because Rotem tests are a long time, it can take maybe 10, 20 minutes, 30 to have a full trace. But nowadays they have a 5-minute parameters, normal reference ranges, and it comes up on the computer of the monitor, and you can in less than 5 minutes have a result. Plus, what is the length of the time for you to send to the laboratory and receive standard coagulation tests? Rotem is faster. 5 minutes is more than enough.
Muhammad Mad is also asking the last question: is neuroaxial block is contraindicated with antiplatelets?
Is neuroaxial? I leave that to you, Dr. Magdi. You are an expert in this.
No. This is beyond the scope of Rotem. But normally, French guidelines of surgeons prohibit using neurosurgery that might be extrapolated to spinal anesthesia if the platelet is less than 80,000. And if the patient, now we have many antiplatelets. According to the half-life, if the effect of the operation is included in the half-life of antiplatelet, so it is contraindicated, at least medically. Okay, I think now another question. Hani Abdel Galil, if a trauma patient received Wolven for station, it can affect the Rotem results?
Well, dextran affects it, but for Wolven, I don't think, but usually we're using these days 5% albumin more. Wolven can affect but it needs more studies. There are controversial data about this.
Also, another question from Mohammed Salim. Do you support the use of prophylactic use of antifibrillatic drugs in cardiac and spinal surgery?
As we said, we're not going to give anything blind anymore. We are going to give it based on findings that you see in Rotem. The only thing that you give blinded tranexamic acid is when you have a severe trauma case coming in the OR, in the ER room. This is the only thing.
Do we need to do routine Rotem for all patients, or we monitor the patient if bleeding starts?
Not for every patient, because it is expensive. We will monitor the bleeding status, but in liver transplant, we have to do it routinely for every patient.
Last question from Mohammed Salim. What is the value of Novo-7 in pediatric patients?
I have no information about this. Maybe Dr. Magdi knows.
No, it was, actually speaking, if transplanted, previously the first indication was hemophilia, which is given to a pediatric patient. But we are still a little bit afraid from the small size of the hepatic artery, so might be deleterious. As you said, there is no research work about that, but from theoretical extrapolated to our patient, it could be used. Thank you, Professor Khaled, and I wish I see you again in Liver Institute.
Thank you, Dr. Magdi Khalil. All my regards to our colleagues in Menifee University National Liver Institute, to my colleagues in Egypt, and all over the world, because I know these webinars are watched everywhere. I can see the data, Dr. Walid. You're doing a great job, Doctor.
May I have a question myself, please, if you allow me?
Yes, please.
The question beyond the thing is not free. You have to pay it. You have to pay for Dr. Khaled.
That's fine. Okay, so in order to ask my question, allow me to share this screen for a few seconds. Can you see my screen, Prof. Khaled?
Yes.
Perfect. So this is what we do in our institute in the Mater University Hospital in bleeding patients. And this is the approach we do. And I need, just to make it simple, and you correct me if there is any mistake in our approach. So, this is a simple Rotem, FibTem, XTem, InTem, and HepTem. We look at the top two only, which is a FibTem and XTem. And we are trying to make it as simple as possible for all juniors. So we look at the A10 in the FibTem, and the normal here is more than 8. And if this normal more than 8 is impaired, I mean, if it's less than 8, we give fibrinogen 4 grams. And then the second step in our approach is to look at the clotting time in the XTem. And the normal is less than 90. And if it is prolonged and more than 90, we give plasma 2 to 4 units. And the next and the third step here is the A10 in the XTem. And the normal is more than 35. And if it is less than 35, this is the time to give a pool of platelets and then repeat the Rotem and see again our approach, how it worked. This is what we do. I will leave it here for yourself to correct me if this approach is, I think it is very simple and very approachable to the junior trainees if they have a facility of the Rotem to approach. We don't look at the HepTem at all or the InTem at all in post-cardiac surgery or in trauma or wherever we are managing bleeding. What do you think about this approach? You are the expert in this field, and I want to make use really of your experience here. Do you agree on this approach? Or
this approach is very reasonable, especially that you're using the 10 minutes, and this will give you a rapid effect. And it's very important that you are teaching the junior staff the importance of Rotem. Nowadays, we're also teaching it in the final year's medical students, and it is available everywhere. Yes, 10 minutes is very good, but of course, XTem and FibTem will give you a very good idea. HepTem, you don't need it unless you have a problem like heparinoids that is secreted in liver, or unless you have a serious coagulopathy situation which is not responding to the usual measures. So you have to look for reasons. So you will have to measure the heptem and see if you have heparin-like effect. So this is not usual to do. The intem, you use it if you want to measure intrinsic pathways, because this one represents the intrinsic pathways. Usually we do the three. To be very clear, in Germany, they do extem, intem, and fiptem, the three.
Okay.
Because if you do extem only, then you will miss the intrinsic pathway.
Perfect. So
So
you
I
don't
would
have an objection
encourage you
to this
to add
approach.
the intem to your.
Perfect.
Yeah.
Yes. Yeah. Agree. Very good. So thanks very much, and I will stop my share here now.
It's very great that you have Rotem in your hospital. Thank you.
Perfect. So, any more questions, Prof. Magdi, before we proceed to the next session?